So on to the next slide, and prevention of back pain. How to avoid back pain. I mean, these are not conclusive, but there are ways that will help. So sitting tall, standing tall, walking tall. So in other words, maintaining good posture, looking at the way you sit in any office environment, making sure that you're not twisted if you've got a computer screen on one side, staying balanced, all of these sort of things, having lumbar supports, etc. So just pay good attention to those. And if you get back pain, mobility is the key. Years ago, if you went to the doctor and you had back pain, they would say, go home, lie on a flat surface, don't move. We now know that that's the worst thing that you can do. You've got to keep the tissues mobile, and therefore soft tissue therapy is excellent for most forms of back pain. Lifting, obviously there's all sorts of courses that you can do on manual handling and how you keep balanced, keep the weight in between your feet, keep the centre of gravity through the core of your body, and make sure you don't lean in one direction or the other. These are great things to actually follow. Usually back problems are initiated where it's that momentary lapse of concentration, and it's often not where you lean forward, but it's usually involving a twisting action at the same time, where we forget, we lean forward, pick something up, maybe it turns out to be heavier than we thought it was, and we strain something in the back region at the same time. So yeah, think hard about how you can help your clients maintain a healthy lifestyle and protect their backs, so that they're not one of those, or end up being one of those statistics where people suffer long-term back problems. Okay, so following injury, regain and maintain flexibility, goes without saying. Regain and maintain strength. So strength is a key thing that we haven't looked at as being quite so important as we now do in current day modern medicine. And certainly with the elderly population, we used to concentrate so much on mobility and flexibility. Now they're seeing that strength is a far more important element to concentrate on in terms of maintaining a healthy lifestyle and preventing other diseases and such like. So really important and key area. Maintain good posture, avoid sitting for long periods of time, so particularly drivers, encourage them to stop, take a walk, do some mobility exercises. If they're stopping for petrol and things like that, make sure they've got a good distance to walk, don't try and draw too close to petrol stations, that you just walk a few yards, get some exercise going and such like. So on to shoulder injuries, common area, very complex area, and a lot of people don't like dealing with the shoulders because it is so complex. But if we start with a common area here, the AC joint, or the acromioclavicular joint, so the union between the acromion process and the distal end of the clavicle here, you may be able to see, but if you can't have a good look in an anatomy book, you've got a very tight joint there, should only be about 3 millimeters. And of course this forms an axis. You've got the sternoclavicular joint here, which is your main union between the axial skeleton and the whole upper limb. You've got the scapula that moves around the thoracic cage. This is the second joint, if you like, away from the axial skeleton. So anytime you lift your arm up, move it around in a horizontal plane, the clavicle will rise, fall and move anteriorly and posteriorly, and this axis point here serves to assist with all of those movements. It can be disrupted commonly by landing on an outstretched arm and driving the shoulder upwards. So you can imagine the head of the humerus here pushing up underneath the acromion process in a forced action, an aggressive action, and this joint separating, so this can move apart. Now there's a very tight capsule that overlaps and holds this all in place, but that can get disrupted. So we can get sprains that occur here in first, second, third degree, or it can separate completely. If it separates completely, you can see there's very little holding it in place, but you've got other ligaments that span from the coracoid process underneath here, this finger-like projection that again comes forward from the scapula, You've got ligaments that come up underneath the clavicle and can hold that in place. So it's rare that everything will get disrupted. That would be a really bad sort of accident, and that would leave this sort of floating around and no union whatsoever with this. And that would require some surgery. Surgery, unfortunately, is not that successful, so you've got to hope that your client, if they disrupt the AEC joint, is not that severe. So what can we do? Well, we can't do anything directly with the joint itself, because you can't really get in there and do any frictions or anything over the joint itself. You've got to allow that healing process to take place. The key here, of course, is again just mobility. Your client will probably come in with some discomfort. They'll be used to, by this stage, of not lifting their arm up. They'll recognise the fact that the more they come up towards a horizontal alignment for the upper arm, the more painful this becomes. If they bring it across their chest, this will put pressure on this joint and it will be very uncomfortable. So our job is to loosen everything up, because everything around this area will be protecting. So you'll have a degree of contraction, possibly even spasm taking place, where everything is tightened up to try and protect and hold this position. So we get in around the upper traps, the rhomboids, around the rotator cuff, around the pecs, around the front, loosen everything up, and you will find that your client will get a degree of comfort and mobility. So they may come in saying, oh, that's as much as I can do, it's really painful when I get to there. By the end of the massage, even if you go another 15, 20 degrees of abduction or whatever movement it happens to be, that's a gain, that's important, because that will increase the rehabilitation and the healing process that is taking place around the joint. The more mobile they can become, the more movement that can occur here, and so you can accelerate the whole process. So don't think, oh no, this is a joint problem, I can't touch it. Think about the surrounding musculature, what you can do to actually improve these things and the general mobility of that. And I guarantee if you had somebody with an AC joint disruption and you were working with them, even on a weekly basis, you will find that you will accelerate that process quite rapidly. Excuse me. Fractured clavicle. Often people say, oh, I've just broken my collarbone, not serious. Again, it depends whether it's been displaced or not. You've got to remember what we were talking about with brachial compression problems. You've got the whole brachial plexus and nerve supply coming in underneath that mid-shaft position, and you've also got your arterial supply to the whole upper limb. And if this becomes disrupted, if it's shattered, if there's a splinter, if there's displacement, you've got the dangers of shards of bone or a jagged point that can be embedded in those vital structures that are serving the upper limb. So potentially very, very serious indeed. So what we would do is make sure that it's been properly examined, x-rayed, and that there are no real dangers there. If the bone hasn't been displaced, they'll probably just put your arm in a sling to immobilise it, to allow the healing to take place. And then again, a soft tissue therapist, once they've got the arm out of the sling, we've got a lot to do with adaptively shortened muscles, not just in this region, but your biceps, triceps. If they've been immobilised with your arm in that position for a long period of time, they can be really stiff, really short, really tight. So you've got to do lots of rigorous stretching with them, soft tissue work to really sort of loosen them up as much as you can. So huge amounts for us to do, even though it's still a bony structure that's been damaged in the first place. Onto rotator cuff strains. So these, again, are very common injuries, can be involved in any sort of throwing type activity, which of course can involve a massive number of different sports. Can be in tackling as well, in hockey, rugby, anything like that. Anything where the arm gets pulled back or wrenched, you've got this integral group of 4 key muscles that hold the head of the humerus in place. So if you're standing in a neutral position just with your arm by your side like so, the muscles can be fairly relaxed. As soon as you move your arm in any plane whatsoever, the rotator cuff muscles will contract to anchor the head of the humerus in place. You've got to bear in mind this is a very shallow skeletal joint. You've only got a very thin sort of shallow disc there in the glenoid fossa. That's extended slightly by a labrum that encases the head of the humerus further. So it's a volatile joint that is subject to subluxation, dislocation, unless that integrity is maintained and that stability by these muscles. And of course, any sort of over-aggressive action, pulling the arm back, overthrowing, anything like that at all, can strain the rotator cuff muscles. So once again, work for us to do. You've got two major muscles around the back, on the back of the scapula, being your infraspinatus and teres minor muscles, and they are responsible for external rotation. In the top there, you've already been dipping your fingertips in just beyond the spina scapula, sort of getting in behind the upper traps and into that fossa. That's onto supraspinatus. And the only part that you can really get access to for subscapularis is around the front of the joint capsule, because it disappears into the anterior surface of the scapula, but behind the rib cage. So obviously we can't get fingers in there to do very much with that. But again, it's knowing what you can do to strengthen and stretch those muscles. So you may have somebody in the sort of standing position with the elbow at the side, doing internal and external rotation, abduction for your supraspinatus muscle, or you can bring them up to a more sporting position with the arm horizontally abducted, and then from here, that would be your neutral position. You can do external rotation, internal rotation, and you can both stretch from that position, or you can do strength movements or strength exercises using a resistance band. So pulling it up or hooking it above and pulling it down. And of course you can use door handles, things like that as well. So just use your imagination, use the tools that you've got like resistance bands and so on. And again, you can do a huge amount of good work here. But it's a very common problem that affects so many sports people. So it's going to be a real bread and butter injury for you. Bursitis problems, again commonplace, and the particular one that you'll hear so much about is what we call the subacromial bursa. And you'll hear the condition subacromial bursitis, so where there's inflammation of this bursa. So subacromium, below the acromion process. So this bony prominence here, underneath you've got a bursa that sits there and protects against friction. So the other main muscle that we've just mentioned is supraspinatus, that comes through, over the top and onto this greater tubercle of the humerus, and above that is this bursa, this fluid-filled sac that prevents friction. Now, if supraspinatus becomes inflamed because of a tendonitis problem, or if there's a compression injury, or there's general biomechanics that are not right, that can compress on the bursa and irritate it. And once it becomes irritated, it can become inflamed. And then you've got a cycle that it can be a real problem, because you've got a bursa that's now inflamed. It's filling a compact space that was causing the problem in the first place. And so you get this cyclical exaggeration and acceleration of the problem. One of the common things can be a postural deficiency, and typically this affects bodybuilders where they do a lot of chest work, build up the pecs and such like. They don't tend to stretch enough, so what they do is they get a very protracted position. You see them with the big lats, the pecs and so on, draws the shoulders round. If the shoulder comes forward into a protracted position, it also narrows that subacromial gap, and that puts pressure on the bursa. So first thing to think about is, can I get the shoulders back? Can I increase that gap and take the pressure off the bursa? It's a difficult condition to manage, because as I say, once you get into that cycle, how do you allow time for it to be alleviated and the problem to go away? So ideally you've got to get them to rest from the activity that's causing the problem in the first place, but again, massage around that area to take as much pressure as you possibly can away from this. Excuse me. Okay, on to dislocations, subluxations and dislocations. So a subluxation is where the shoulder or a joint comes out partially. A full dislocation is much more serious. If the shoulder fully dislocates, then you've got a real issue because it's going to come right out of the socket, and of course it will then have probably torn lots of other tissues, maybe muscles, maybe the labrum, maybe also the joint capsule around it, and that's going to involve possible surgery to put it back, but it's going to leave you with a very lax joint. Subluxations, less serious but still problematic, where the head of the humerus can literally flick out of that socket but just drop back in again. So it's not such an aggressive action that's taken place and not such extensive damage to the surrounding tissues. But again, we have to think how we're going to resolve this in the long term, how we're going to reduce the risk of injury. So massage to alleviate and correct the biomechanics is always good. Take the tension out of the surrounding muscles and any protection that might be taking place, but also to strengthen the rotator cuff muscles to improve the integrity of the muscles. We can't shorten them, so we can't draw the head back in, but we can strengthen them so that during action the integrity and the stability is maintained, and that's the key thing for any sporting activity. On to frozen shoulder. This is a horrible one that not many people really like, because frozen shoulder can be a number of different things. It can be a nerve problem, again with the brachial plexus, that is causing problems down in this region. It can come from the neck. It can be a capsulitis problem. It can be a bursa problem. It can be rather vague, and it can be very difficult to resolve. So a true frozen shoulder is a difficult one to resolve. So what can we do as soft tissue therapists? Well, just go through your normal routine of how you would assess. Checking for passive movements, checking for strength, doing a palpation, and just eliminating as much as you possibly can. And what may present as a frozen shoulder in the early stages, again, may turn out to be something different and can possibly be alleviated by massage, taking pressure off nerves and that sort of thing. So again, looking at brachial plexus, working your way all the way up to the neck, and just alleviating all of the muscular tension that can occur from the neck right down to below the shoulder region can help with this. But true frozen shoulder can come on what we call insidiously. In other words, it can come on without any particular cause. Post-surgery is a common time that true frozen shoulder can come on, and it can stay with you for months, even years, and then it can just magically disappear at times in the same way that it arrived in the first place. So if you're getting these sort of problems, accept the fact that you may only be able to alleviate some of the symptoms. You may not be able to cure the problem. That may take further work or even just luck in the end. Okay, tends to affect people that are more middle-aged and latterly, because shoulder degeneration is generally one of the joints that tends to degenerate fastest, and you tend to find people around their mid-50s onwards start to get shoulder problems where lifting it above horizontal becomes more difficult. And that's often the case when you find somebody who's in their 80s and 90s. What's one of the things that you help them with most is probably getting things out of cupboards above shoulder height that they can no longer do. So one key message to people in their latter years is keep exercising, keep doing overhead type activities to keep the shoulder mobile, to keep it strong, and to prevent that degeneration that takes place. Okay, move down to the elbow region. The elbow is a very complex area, but it's quite a secure area, so dislocations and such like are not commonplace. When they do happen, they're usually a particularly sort of aggressive action that takes a lot of force to actually pull those bones out of place. So more common things that we might be dealing with would be tennis elbow and golfers or javelin elbow. So when we look at the two epicondyles, these two bony prominences either side here, so when you're standing in the anatomical position, we know about these two bony prominences. We've probably done this already with you during palpation. but if you feel for your medial epicondyle on the inside, closest to the body, this is the common origin or bony area for your wrist flexors. So any movement that involves wrist flexion, if you just palpate just below that bony prominence, you'll feel your wrist flexors contracting. And when you've got some sort of jarring action, typically when you're striking a golf ball or something like that, the vibration will travel up the shaft of the club and it will reach that point close to the origin there where you get micro trauma in the tissue and you get inflammation, and so you get this very tender or sore point developing. As it gets worse and worse, it can get to the point where it's so painful you simply cannot play your sport any longer. Same is true with tennis elbows around the lateral part. So again, if you're standing in that anatomical position, this bit on the outside, the lateral aspect is that epicondyle, and this is where your forearm extensors have a problem. So again, what can we do massage-wise? Just think about the tension that would be created in either the flexors or the extensors around this aspect or this aspect of your forearm, and think about how you can massage, doing box squeezes to really alleviate the stress in that area, because your body will always fight to protect and tighten up those muscles. So you need to get the tension out of particularly this area, but see how it's tracking up into your biceps, triceps, and again the key areas up in your shoulder region. Don't ignore upper traps, neck muscles and so on, because you'll start to carry the shoulder in that elevated fashion, and that will have an effect on all of the biomechanics of that particular region. So both of those epicondylitis conditions, as they're more technically known, are going to be commonplace, just as the rotator cuff muscles are. Bursitis problems, the common one, I say common, it's not that common, but you get something called student's elbow. So around the olecranon process, this bony prominence here, if you rest on that for too long, typically when you're resting your elbow on a desk or something like that, that little bit of friction there can inflame it, and you will find that this will balloon up. And again, all you can really do is rest that, perhaps put on some arnica cream or something like that, a natural anti-inflammatory cream, or allow your doctor to prescribe anti-inflammatories to bring that down. Moving on, we mentioned dislocations earlier. It's a very strong joint. If the bones do dislocate, then again, soft tissue wise, you've got a big job on your hands, because this is a hinge joint that locks. So getting flexibility back once that dislocation has taken place, inevitably they will have immobilized for a while, probably had an arm in a sling whilst the joint has been relocated. You'll get that adaptive shortening around the capsule of the joint, but also the muscles, and in particular your biceps. So stretching biceps is a difficult one, particularly when you've got a bony block there and you can't stop it, or you can't extend it any further than that. So you're going to need to work on the muscles, really soften them up as much as you can. And for a bicep stretch, if you remember, it's taking your arm out into a horizontal position, back as far as you can into horizontal abduction, but also then rotating so your thumb is down towards the floor, and that is the best means of stretching biceps that you can actually do. So softening the tissues up, stretching them, and possibly doing strength work as well latterly as you get through those early stages of rehabilitation. So moving down to the forearm and the wrist, tenosynovitis is a condition that the words tell you everything. Tenosynovitis. So teno tells you there's a tendon involved. Sino suggests that there's some sort of synovial fluid involved, and this tells you something about the structure that has been damaged. Where there's tenosynovitis, it means that there's a fluid there, and that fluid is lubricating the movement of that tendon. That means it's usually going round a bony prominence. So there's not a direct line from the muscle belly through the tendon to its point of attachment. So typically round elbows, ankles, etc., where the muscle is in one place, but the tendon tracks around a bony prominence, this is where there's potential friction, and you'll get this synovial fluid in a sort of soft tissue or a connective tissue tunnel that lubricates that area. If it becomes inflamed, then obviously you've got a problem there, and I would say leave the area of inflammation well alone, because if you start working on that, you'll probably inflame it more. Track back to where the belly of the muscle is, loosen up the tension, that will take the strain off the tendon itself, and that will be your best route to rehabilitating that type of problem. If this gets more serious and it's allowed to perpetuate for too long, then you get what we call an inflammatory exudate building up in that tunnel, and sometimes that can crystallize if it goes too far, and those crystals can also adhere to both the tendon and the inside of the tunnel itself. And that can lead to a condition that we call crepitus. Now, crepitus is usually an audible or a palpable grinding sensation. Okay, it's not a clunk or a click where you may get a tendon flicking over a bone in a consistent way. This is more like a rasping of a sort of sandpaper, and it's these crystals that are grinding over each other. More difficult to actually get rid of, because you can't get into that area and start doing frictioning and dislodging them, because usually where that tunnel is will be others that serve arterial blood supplies, venous return, nerve supplies, and you don't really want to start getting in there and irritating those. But you've got to try and dislodge those crystals somehow. So try and get in there with a little bit of thumb work, try and disrupt them, allow the body to reabsorb those crystals, and that will help with the condition. So that's tenosynovitis becoming more chronic and ending up with something called crepitus. Crepitus is just a description of the sound or the crunching type of sensation that can occur. It can occur anywhere in the human body. Carpal tunnel syndrome is a common one, particularly with computer-style activities and the excessive amount that we tend to do on them. So the carpal tunnel is literally, you can see where there's this U shape in the carpal bones in the hand, and through that U shape will travel all of your tendons that serve your fingers and your hand, but also your arterial supply, your venous return, your nerve supply, and it's all compacted into that space. There's a retinaculum that sits over the top, and it's incredible how dense and compact that will be. We, of course, have protection over that, so this area of the hand that we call the thenar eminence that we massage with, if you feel that, there's a lot of soft tissue over there, sort of, which protects that carpal tunnel. But inside there, if that becomes inflamed, then again you've got this cyclical problem, because you've got a tight space that is now inflamed, and it's going to put more pressure on those structures. But it's quite commonplace these days to have surgery to release the tension in there, quite a quick operation, even though there's a lot of delicate structures in there. But hopefully, by alleviating the tension in the forearm flexors and maintaining a healthy lifestyle, so we're easing back on the activity that caused it in the first place, you should be able to alleviate or prevent the problem getting too much worse. Now to fingers and thumb, contusions, ruptured ligaments, fractures or dislocations. Be cautious. What you tend to find, or certainly I've found in my experience, is that people ignore fingers and thumbs until it's too late. I typically have had many rugby players come to me sort of 3-4 weeks down the line, and they say, have a look at that finger, and there's a big swollen knuckle there, and you feel it, and it's already sort of started to calcify and become quite solid. And unfortunately they've said, oh, I thought it would disappear, so I left it, and now 3 or 4 weeks on, it doesn't matter what soft tissue work you do, you're very unlikely to be able to dislodge it and get it back to normality. And typically you see cricketers, rugby players who've played a lot of years in their particular sport, and you look at their hand and all the knuckles are sort of gnarled and swollen and fingers bent out of place and so on. And again, it's just that typical scenario where they just leave it thinking, oh, it'll go away. And unfortunately, you've got to try and catch soft tissue problems when they are still literally soft and they haven't sort of solidified and become too problematic. So it is a real difficulty in soft tissue therapy, trying to encourage people to come forward and get treatment early, even when they sort of think, oh, that's a bit sort of namby-pamby, I don't want to trouble them. Get them into that mindset that, yeah, if you get it treated early, it's going to take a lot less effort, it's much more likely to be resolved, and therefore shouldn't be a long-term problem. Ruptured ligaments, so around these joints, typically catching balls, getting fingers bent back and such like, can tear ligaments around the joints. Fractures and dislocations, do be cautious. Having played many years of rugby, I've seen many situations where somebody will dislocate a finger and be bent out at 90 degrees, and he'll literally offer it out to the rest of the team and say, somebody put that back for me. And you'll see people queuing up to try and reduce that joint, put the finger back in place. Shouldn't really be done, because at that point you don't really know whether it's dislocated or broken. And if there's a shard of bone sticking out and you start waggling it around, you could do a lot more soft tissue damage than good. So do be cautious about that one. And scaphoid, final one. So the scaphoid is just below the base of your thumb. Can be identified through the anatomical snuff box. So if you abduct your thumb or hold your thumb up like that, you will see or feel two abductor tendons. And the gap in between is known as the anatomical snuff box, because that's where, in the olden days, people used to put tobacco and snuff it up through the nose like so. So that's the way it's got its name. If you put a little bit of thumb pressure on yourself, pushing towards the thumb, not back towards the wrist, you may find a little bit of tenderness on that bone. That bone is the scaphoid. It has a neck in the middle. If it fractures, it has a rich arterial blood supply to one end only. And so it's got to be rejoined quite quickly for a union to take place. And again, it can go unnoticed. Typically, if somebody falls on an outstretched hand and hits a hard floor or a hard surface, that's where the scaphoid will fracture. They take it very seriously in hospitals these days, particularly with youngsters falling off bicycles, things like that. They'll x-ray, and often, even as a precaution, they will put you in a splint to stabilise the thumb. And of course, very often they can't see it on an x-ray in the early stages, so they'll get you back 2 or 3 weeks later, have another look at it and see whether it's starting to resolve, if it was a fracture or it wasn't. So extreme caution, any sort of pain in that area, don't ignore it, particularly with youngsters. You can do that simple test of just pushing in that base of the thumb there. But as I say, make sure you push towards the thumb and not back towards the wrist, particularly if you're doing it on somebody else. Okay, so that's an overview of everything from the head down to the pelvic rim and covering the shoulder and the upper limb region. Hopefully that's given you a really good idea of what to do with soft tissues, and not to sort of just think, oh, it's to do with bony structures or it's to do with joint. As I hope I've illustrated clearly to you, we can do a lot of things with a lot of conditions indirectly because of the effects to the surrounding muscular tissues and the biomechanics that in turn will also be adversely affected. So that indirect route is going to be a really good mechanism for accelerating the healing process, moving the rehabilitation on, and getting people back risk-free or a lot less injury risk orientated than they might have been if they're just left alone. Thank you.